Senator Boye.
Thank you, Madam Chair, and thank you, Minister Lametti, for your presentation today. And thank you to Senator Martin for bringing up the topic that I'm going to talk about as well. So during the consultations that we had with Indigenous people on the pre-study and C-7, many common concerns were not addressed in this bill. And among those shared concerns is that an Indigenous person may feel like they may have to choose MAiD due to the lack. My question relates to the effectiveness of the safeguards found in subsection 31G and 31H of Bill C-7 that require a medical practitioner to ensure that the patient wishing to access MAiD has been informed of all the means available to them to relieve their suffering and has given serious consideration to these alternative means. In the context of unequal access to healthcare that primarily affects those who would be most in need, how will these subsections serve as truly effective safeguards for all Canadians, including Indigenous peoples?
Thank you for that question, Senator Boyer. Again, it is profoundly important in the larger context of how we deliver healthcare across Canada and our aspirations to do a much better job with it. I certainly share the view that we need to work with provincial and territorial governments to ensure that healthcare is the delivery of healthcare is improved across Canada, and that particularly in remote northern regions of the country, particularly in Indigenous communities, that healthcare delivery be done better. I work with my colleagues around the table, Minister Miller and also Minister Qualtrough, with respect to the disabilities aspect of it, to make sure that we're pushing as hard as we can for what can be done by a federal government to aid, promote, provide resources, etc., to make sure that that healthcare is of the highest standard, and we work with the provinces, obviously, because it is their jurisdiction. So I fully share that. This act, this project, or projet de loi, this act bill in front of us is about autonomous choice, and making sure that individuals are aware of the options that they have to live with dignity or to choose MAiD based on their condition and based on their evaluation of that situation. And that's the role that I have, and I'm hoping that this piece of legislation will provoke the kinds of discussions that need to be had, where the provision of a meaningful alternative for whatever reason isn't up to the standard it should be at. And I think those discussions are already beginning to happen, which is a good thing. And hopefully we can move the dial with respect to the examples that have I think are the most obvious with respect to the provision of health services in remote northern and Indigenous communities, as well as the provision of services to the disabled, will hopefully improve, having been, I think, nudged along by this piece of legislation.
Thank you very much for that answer, and I hope to see that as well.
Thank you, Senator Boye. We'll go to Senator Boye.
Thank you, Madam Chair. My question is for Chief Commissioner Landry and her team. As you are well aware, Indigenous people who are disabled in Canada face multiple forms of discrimination. They must deal with the effects of colonization and racism, as well as the societal perceptions of their physical and/or mental abilities. Unfortunately, Indigenous people often do not receive the care and services they are entitled to because of jurisdictional disputes between federal and provincial governments. In your opinion, should the government be removing the foreseeable death clause if there still exists jurisdictional disputes over which government should fund necessary health services for Indigenous persons with disabilities? And what steps should the federal government take to ensure that Indigenous persons living on reserve who are disabled do not access MAiD out of desperation because they are unable to access necessary health services.
Thank you. Sorry. Thank you, Senator Boyer, for your question. Marcella will answer this question.
Thank you, Madame Landry. Certainly, we share the very serious and long-standing concerns about the impact of colonization and the intergenerational trauma that has left the conditions of systemic discrimination affecting Indigenous populations in Canada today. We've raised this concern a number of times, both domestically and in international fora. You've raised a couple of questions. One of them is the shared jurisdiction, and that is always a tricky one. We've been encouraging the governments responsible for human rights to reinstitute regular meetings to discuss the shared jurisdiction on human rights issues but amongst themselves on a regular basis to help iron out or to work through jurisdictional issues before they arise in individual cases. And we certainly want to ensure that that takes place in a manner that avoids particularly tragic circumstances like those we know of in the past. You've also raised the question about ensuring that Indigenous persons on reserves have the appropriate services, both to support their health and well-being, but also perhaps to receive MAiD in appropriate manners. And I think we strongly support some of the other testimony that you have heard about the importance of culturally appropriate services, both in terms of delivering health services overall and in the process of delivering a dignified death where that is requested. And that must ensure the involvement of the communities themselves, including where it's appropriate, the involvement of elders, so that the events around providing a dignified death are not narrowed to a medical or a physician-oriented process, but that they can fully encompass the ceremonial and cultural importance that exists for many Indigenous persons. And in that way, it can both help to move forward on reconciliation on an individual manner, but it can also ensure that we are respecting the role of Indigenous persons as we seek to provide them with dignified services in health and in death. Does that answer the question?
Yes, thank you, Marcella, and thank you, Chief Commissioner.
Yeah. Senator Boyer.
Thank you.
Thank you, Madam Chair. I'm going to pick up a little bit on what Senator Batters has just asked, but my question is for Dr. Dusani. So we know, we've heard through the pre-study and we've heard this evening that a common concern among Indigenous communities and disability organizations is that the expansion of MAiD may disproportionately affect Indigenous persons and persons with disabilities if these individuals do not have sufficient access to healthcare or support services. As you know, lack of access for healthcare is a serious concern for the population that you serve. So in your opinion, are the safeguards that are in Bill C-7 sufficient to address these concerns? And do you believe there are additional safeguards that this committee should be considering to offer better protection?
I think it goes without saying that due to ableism and the longstanding effects of systemic racism, the impacts and inequities we see as outcomes for people with disabilities and people who are Indigenous in our communities are grave. There's stark differences. You know, for example, in Toronto, people experiencing homelessness represent 25% of the homeless population, but 1% of the people who live in the city, for example. And so when you know, again, my understanding is Bill C-7 is likely to pass. Canadians have spoken. We're moving ahead. If we don't build up the structures around them, around money, around housing, around harm reduction, around mental health, people will be put into vulnerable positions where they may be more likely to choose medical assistance in dying because they don't have access to care. And I just mean any kind of care. Palliative care, sure, I'm a palliative care doctor, but healthcare, primary care, food, money, and so on and so forth. And you know, when you look at the safeguards that have been put into place, I could get into the minutia of like making small suggestions of little moves here, you know, right or left, micro movements. There's no micro movement that can really protect people other than investing in housing, other than investing in basic income strategies, pharmacare. And you know, I know that these are not mutually exclusive processes. So I know I'm coming off somewhat you know, like an ideologue, but I'm not. I also appreciate these are not from the same pool of resources at the same time. But this energy, this kind of like motive to just get this through, and I think because it's tightly packaged and it's a medical procedure, we can do it. I just hope we have the same energy around these other bits that really can derive equity for people. I don't think there's any specific micro change I can suggest to address what I'm talking about, which is essentially suffering due to inequities, due to ableism and racism. Thank you for that question.
Dr. Dasani, if you wanted to elaborate any further on what measures you think the Senate should be taking and with respect to these areas, recognizing that we have no ability to invoke any kind of legislation that involves the government spending, but in light of the fact that the government during this process, during COVID, has indicated that, you know, has pivoted and provided national initiatives, that, albeit that have left, you know, 1 in 10 people in Canada behind, I would welcome that addition if you would like to add anything further at this stage.
Well, thank you so much. And I appreciate that the focus of Bill C-7 is not particularly this component, but the conversation needs to happen that MAiD has highlighted structural vulnerabilities like my colleagues across the country who've talked about today, and we need to work to address them. The first is the National Housing Strategy Act, which really needs to be put into play. For those who aren't aware, the Canadian Alliance to End Homelessness Recovery for All campaign provides a 6-step approach to ending homelessness in Canada. It is tangible, it is doable, we can cure homelessness, and COVID has shown us that we can do that. I think another piece to consider is the role of basic income in ending homelessness in Canada. And another one would definitely be pharmacare. Given that 1 in 10 Canadians cannot afford medications, this is an important upstream social policy that can derive change. And scaling up harm reduction approaches and services across Canada, from supervised consumption sites to overdose prevention sites, and the licensure that's needed to do that has to be part of these kinds of conversations. I said it before, I'll say it one more time very quickly. It's okay with me if Canadians have spoken and the person I care for wants to get medical assistance in dying. Fine, we'll get it for them, but it'll be neatly packaged in 2 weeks. We'll get it for them. It'll go down. It'll happen. But it takes me years to get people housing. It takes me months to get them income supports, and it takes them weeks to months to get them mental health and addiction services. And that is morally distressing for frontline health workers like me. You can see what I'm talking about. It just doesn't fully make sense, although I appreciate that's not the full capacity of this conversation. Thank you for the question.